Hello friends. So the most common cases that you get in your DNB or MS exam are basically PIVD. It could be cervical or lumbar PIVD, port spine, scoliosis, spondylolisthesis, lumbar canal stenosis, cervical myelopathy, ankylosing spondylitis, or any fracture. Fracture could be a simple traumatic fracture or a pathological fracture. So now the case could be presented as a long case or a short case, but here from academic point of view I'll be presenting it as a long case because it depends on your examiner and your center whether he wants it as a long case or a short case. If he wants it as a short case, then you have to just tell the positive points. However, if the examiner wants a long case, then at least you should know how a long case is presented. So now let's start here. The typical history looks like Mr. Rajkumar, aged 41 years, residing at Alka Colony, belonging to lower socioeconomic class, came to XYZ hospital during emergency hours 3 days ago with complaints of. Now it is important to mention here the age and the gender of the patient because age tells you or gives you some idea about the pathology, like lumbar canal stenosis occurs later in the age, and gender of the patient is also important because like in case of scoliosis, which is more common in females, this thing has an importance. So now proceeding with the history. So now, like I said, this patient came to emergency department. So that also has an importance because that means the patient was in severe pain or there was a seriousness in the situation when he came to emergency department. Also, the term belonging to lower socio-economic class or middle economic class carries an importance because in case of tuberculosis, which is more common in people living in unhygienic conditions, that has some relation with the socio-economic class as well. So in this case, the history goes like this. He had low back pain since 20 days, left lower limb radicular pain since 10 days, numbness and tingling in the leg since 17 days, difficulty in walking since 5 days, and was unable to pass urine since 1 day. Now, unable to pass urine, that is an emergency situation for which he came to emergency department. Now, based on this history, you should get some provisional diagnosis in your mind. Like in this case, there was low back pain, left lower limb pain, numbness, tingling in the leg, difficulty in walking, which was due to weakness, and unable to pass urine. So now in this situation, this could be a case of lumbar PIVD or a case of port spine or a case of spondylolisthesis. But this cannot be a case of scoliosis. This is not the case of lumbar canal stenosis. This is not a typical presentation of myelopathy, or this is not even anywhere close to ankylosing spondylitis. So now moving on to the HOPI. So here we have to talk about, was the patient absolutely okay 20 days ago? Was he able to carry out all his activities of daily living? Like if he was a postman in his profession, was he able to walk or climb bike, or was he able to deliver the posts? Also, it is important to tell whether he was seen by any local doctor earlier or not, whether any treatment was taken, whether in the form of medicines, rest, traction, physiotherapy, or whatever. And also the duration is important here because in if you say it was a myelopathy, then myelopathy is normally slowly progressive, whereas a fracture is fast progressive. Now, when you talk about the pain, you have to be very specific and you have to cover all the points of pain, like whether it was acute or insidious. Like in case of trauma or discitis, it is a acute pain. Whereas if the pain was mechanical or low back pain or pain due to metastasis, then the pain is slowly progressing. Also, you have to mention about the site of the pain, whether it was in the back or in the arm or in the leg. What was the nature of the pain, that also you should tell very clearly, whether it was a throbbing pain, sharp pain, which is a feature of acute pyogenic problem or a fracture, or it was a constant pain like you get in case of tuberculosis. Also, you have to mention about the radiation of the pain, whether it was radiating to the tip of the finger or back of the thigh or front of the thigh, because radiation tells you about the dermatome involved. Supposing if it is going to your thumb, then it is C6 dermatome. Whereas if it is going to the front of the thigh, it could be L1 dermatome or L2 dermatome or L3 dermatome. Also, in pain, you have to tell whether it was a diffuse pain or a localized pain. Like for TB or listhesis, let's talk about tuberculosis. Like in case of tuberculosis, it is normally a diffuse pain. Whereas in case of fracture or spondylolisthesis, it is a localized pain. Also, you have to mention about the aggravating factors or relieving factors. Like in case of PIVD, forward flexion invariably increases the pain. Whereas if somebody is having lumbar canal stenosis and because of that claudication, forward flexion reduces the pain. Now coming to the next important part of history taking, which is basically the history of trauma or weight loss or fever, cough, loss of appetite, morning stiffness, bladder bowel symptoms, night cries, breathing difficulty. So now everything carries importance here in spine. If there is a history of trauma, you can very well associate it with a fracture. If there is history of weight loss or fever or cough or loss of appetite or night cries, then you can correlate it with tuberculosis. Morning stiffness is typically seen in case of ankylosing spondylitis. Bladder bowel symptoms typically go in case of cauda equina syndrome or lumbar PIVD, or rarely in case of spondylolisthesis also. And breathing difficulty, it goes mostly in the favor of scoliosis, because if there is a large scoliosis curve, then it can cause breathing difficulty. Also, it is important to know the past history of diabetes, hypertension, steroid use, epilepsy medicines, chronic infections in the past. Now, epilepsy medicines also carry a role because anti-epileptics are known to cause osteoporosis. And also the same case is there with steroid use also. So if a patient is there with back pain, having history of epilepsy, has taken steroids in the past, that goes in favor of osteoporotic fractures. Diabetes is important because diabetics are more prone to infection, and also diabetes is important because whenever if you plan to operate a patient, if perioperatively sugar levels are high, then chances of infection are more. Also, you should ask about any past history of any surgery. Now, coming to the next important part in the history taking is, you should know about the family history. Like in case of scoliosis. Scoliosis is 20 times more common in first degree relatives of scoliosis patients. Also, ankylosing spondylitis has a positive family history. And also tuberculosis. If someone has had chest tuberculosis or any other tuberculosis in the family and this patient is a close relative, then of course chances of tuberculosis are high. In personal history, you should always ask about what kind of diet the patient is taking, whether vegetarian or non-vegetarian, Indian, or is the diet normal, is the appetite normal, is the sleep normal. Also, you should ask about the bladder bowel habits of the patient. Also, you should inquire about smoking, because smoking not only leads to disc degeneration, that is increased chances of PIVD, it also increases the chances of cancer, that means the metastatic diseases of the spine. Also, it increases osteoporosis because it reduces the vascular flow, and also smokers are more prone to developing post-operative complications because the blood flow overall reduces. Also, you should ask about the alcohol history of the patient, because we all know that it causes AVN, which is more common in the hip, because AVN is most common in the hip, but there is something known as the spine hip syndrome, so in which the spine gets secondarily involved because of the hip. Because the hips, if the hips are involved, then the curvature or basically the sacral inclination changes because of the overall alignment of the spine changes. Also, if somebody is alcoholic, there are more chances of wound healing complications related to surgery. In case of females, menarche should always be asked. This is very important in case of scoliosis case, because the treatment line depends on whether the patient is premenarchal or postmenarchal. Now, this is how a typical history goes. Now, you should be ready that at the end of your history, the examiner might ask you, summarize the positive points and give me a differential diagnosis based on the history. So if you are presenting a long case, be ready for this question at the end of your history, and you should have at least 2 or 3 differential diagnoses before you move on to the examination part. So like in this case, which we have just now discussed, this could be a case of lumbar PIVD. It could be a case of infective spondylodiscitis, that means tuberculosis, or spondylolisthesis, or any pathological fracture. Now in examination part, let's start with the general examination. I would suggest all the exam going candidates to see our video on YouTube about the general examination. I have also put a description of this, a link of this in our description, because you should know how a general examination should be there. Normally the examiners are not very keen on going into details of general examination, but see that video once. I think it's a 10 minutes video and it is common for all the cases of orthopedics. After seeing that video, there will not be any more requirement for you to study it from the book. And some examiners, they even try to trap you in general examinations because they know it is not your strongest part. So do have a look at that video so that you know what is build, hydration, nourishment, or how higher mental function examination is done, what is the breathing pattern, or where to look for jaundice, edema, lymphadenopathy. These are very general questions, but if the examiner wants to trap you, he can get you in these questions and you can lose the focus of your main case. Now, moving to the local examination, the first prerequisite is that the patient should be adequately exposed. If it is a male patient, then it is preferred if the patient can be only in shorts. In females, depending on the comfort level of the female, try to keep the number of clothes to the minimum. Now, it is important not only to expose the entire spine, the upper limbs, the lower limbs. Also, the foot should be clearly visible, because sometimes a foot may have deformities of cavus or varus, which can be a telltale sign of tethered cord syndrome, spina bifida, or neural tube defects. Also, you need adequate exposure so that you can see if there is any stoop, any balance problem, or if there is scoliosis, kyphosis, or even a list. So, adequate exposure should always be there. Now in exam, I normally prefer telling about the gait at the beginning, but sometimes the examiner might ask you to present it at the end. But for the sake of completion and what is normally followed at our hospital, we normally refer to gait after general examination and before local examination. So all of you should know the definition of a gait. It is basically, as per the textbook, it is a forward propulsion of the body by the lower limbs in a systematic, coordinated, semi-rotatory movement of trunk, arm and head. Now, you should also know about the stance phase, the swing phase, the double support phase or width of the base support, step length, stride length and cadence. Now, these all words are important because your examiner might ask you about these things. Also, you should know what is limping versus lurching. Like in limp, it is basically a reduction in the stance phase due to pain, and in lurch, it is an increased stance phase because of to increase the stability. So, for spine cases, it is important for you to know few gaits. First is, basically, you should know what is a foot drop gait or high stepping gait. This is basically seen in cases of lumbar PIVD or cases of cauda equina syndrome. So there is a weakness of the dorsiflexor of the foot. So the patient will lift the foot or lift the leg higher up so that he can clear the foot of the ground. So it is also known as the high stepping gait. It is seen in cases of foot drop or dorsiflexor weakness of the foot. Now, after some time, the patient starts to use something known as the dragging gait. So if a patient is having foot drop or weakness in the leg, then patient stops making the effort to clear the foot of the ground and he starts to drag the foot on the ground. Sometimes you might see a spastic gait. This is seen in cases of cervical myelopathy because of the hypertonia. Or it can also be seen in cases of pot spine if it is above the level of D12, that means at the level of spinal cord, because in that case you get a upper motor neuron lesion because of the pressure on the spinal cord. So there is hypertonia, hyperreflexia and also spastic gait. Now next is the attitude of the patient. It is important to understand the attitude of the patient, because like in case of ankylosing spondylitis, there is a forward stoop. We call it the poker back appearance. Also, you should know about the positive and negative sagittal balance, because positive sagittal balance means that the patient is bending forward. And this is commonly seen in case of degenerative scoliosis. It can also be there in your case in exam in cases where degenerative scoliosis is having lumbar canal stenosis also. So it is important to know that if some patient is standing like this with lumbar canal stenosis, there might be some degenerative scoliosis also. Normally, the patient with lumbar canal stenosis is forward flexed and they like to hold something in their hand. This is known as the shopping cart sign. So they try to stand in a forward stoop posture. Also, it is important to know that in case of Carey spine, bending forward, the patient might bend forward to hold something so that his body weight is distributed. So this is mostly in cases where there is a acute painful condition and the patient is not able to stand. So the case that you might get in exam is Carey spine. So now coming to the local examination part, you should always start with one line, which is, I have examined the patient in supine, prone, side position during standing, sitting, lying and walking. Now, it is important to understand that what kind of patient you can examine in which kind of position. Supposing now if there is a patient with fracture or painful condition of the spine and you're not able to make the patient erect or you're not able to make the patient stand, then don't say in exam that you have examined the patient during standing or walking situation. Also, in cases like scoliosis, there is something known as the Adams forward bending test. So in scoliosis, you ask the patient to bend forward to see if there is any correction of the deformity or not. So in that case, you have to say like, I have examined the patient in supine, prone, side positions and also during forward bending position. So as per your case in the exam, you need to be very specific in what position you have examined the patient and whether the patient was sitting, standing, lying or walking. Now coming to the inspection part, from the back we see the position of the head, whether it is in the center or not. And we also see the hairline or the length or the alignment of the neck. Now these 3 points are important in case of a deformity or torticollis or in case like Klippel-Feil syndrome. Also we see the level of shoulder, which might be unequal in case of scoliosis. We see the level of scapulae, which might be asymmetrical if there is any congenital abnormality. Even in Klippel-Feil syndrome or in scoliosis, it might be unequal. We see the height of the iliac crest or the position of the iliac crest, because if there is any pelvic obliquity in case of cases like scoliosis, then there might be asymmetry. We see the spinal curvature from the back, because in case of scoliosis, we have to very well tell the examiner what kind of scoliosis it is. Basically, we tell the examiner what site it is, whether it is thoracic or lumbar or thoracolumbar. And also we have to do a forward bending test to see whether it is disappearing in forward bending or not. We have to tell the examiner how many curves are there, number of curves, whether there are 2 curves or 3 curves or 1 curve only, and which is the primary curve, which is the secondary curve or the compensatory curve, or if there is any rib hump on which side it is, or if there is any pelvic obliquity, is there a pelvic obliquity or not. So all these 7 points are important when you are explaining or describing a scoliosis curve. Now next you have to talk about the central furrow also, whether it is at the center or whether it is grossly visible or poorly visible. Also you should talk about the vertebral prominence, that is the C7 vertebral prominence, if it is seen in that patient. Also you should talk about the prominence of paraspinal muscles, because they are more prominent in cases if there is any pathology which is painful. Also you should talk about boarding, that means the spasm of the sacrospinalis muscle, if it is present or not. Also you should know what is renal angle, which is basically the junction of the lower border of 12th rib and the sacrospinalis muscle. You should also talk about the posterior superior curvature of the iliac crest if it is required, otherwise you can miss this point also. You should always talk about dimple of Venus, which is basically the SI joint, whether it is symmetrical, asymmetrical. Also you should talk about any obvious visible swelling, scar or sinuses if it is present behind the back. Sometimes the step of spondylolisthesis is very clearly seen if it is grade 2, grade 3 or grade 4 spondylolisthesis. So if there is any step, that also you should mention. You should also talk about any hair growth or lipoma at the back of the spine, because that tells about any neural tube defect, either open or closed. Also, you should talk about any broadening of the back, if there is any pathological broadening or there is asymmetry of the back. Now, one way is to use a plumb line from inion, and it should pass between the buttocks. So this is basically for seeing the balance. Also, sometimes from the back you can see a list. Now, list is basically a uniplanar sudden bend or curvature of the spine. So here I have shown you the photograph. This is actually one of our operated patient. You can see before the surgery he was having a list. That means there is no rotation, but there is a sudden uniplanar shift. So this is different from scoliosis, because in scoliosis there is rotation and there is a gradual curve, but here it is a sudden uniplanar component without any rotation. So there are three differences between list and scoliosis. It is sudden, uniplanar, and there is no rotation. Also, if there is any scoliosis finding from the back, you should be very particular about mentioning it in detail. Also, you should see for any cafe-au-lait spots, because if there is any neurofibroma, then this particular thing carries a lot of importance and it can be associated with scoliosis. Now, coming to the inspection part from the side, you should always start with whether there is any hyperlordosis or any kyphosis. Normally, hyperlordosis is seen in cases like where we have hip spine syndrome, where the hip is involved and spine is compensating for the pelvic tilt. And in cases where we have kyphosis, we have to be very particular whether it is an angular kyphosis or a rounded kyphosis. Angular kyphosis basically will have knuckle or gibbous type of deformity, where there is a local prominence of 1 to 3 vertebrae. However, in cases of ankylosing spondylitis, we see something known as the rounded kyphosis, which is more of a globular kyphosis. Also, you should comment and see whether there is any stooping posture. Also, you should see about the gluteal bulge. You should always see about any flexion attitude of the hip. Also, see any abnormal shape or prominence of the chest, and you should comment upon the abdominal bulge. Now, coming to the inspection part from the front, you should always see whether the head is centrally placed or the position of the head is neutral. You should see if there is any squint or facial asymmetry, because it might be present in cases of Klippel-Feil syndrome or any congenital conditions with torticollis, where you might have sternomastoid tumor or fibrotic sternomastoid muscle. This will be accompanied by any neck tilt if it is there, or any sternomastoid asymmetry, where you can feel a hard palpable cord-like sternomastoid. Also, you should see the position of the sternum, whether there is any pectus excavatum or pectus craniatum. Also, look for any chest asymmetry. Always see the position of the umbilicus, position of the iliac crest from the front, and any obvious muscle wasting or swelling or any abscess, because sometimes you can see a cold abscess also, which can be present near ASIS or inguinal region or thigh. So when you see from the front, see all these points. Also check for any nipple asymmetry if it is there. Now, coming to the palpation part, normally we start with a line that all the inspectory findings are now confirmed by palpation. So you start with any temperature, local rise, or there is anything cold. Also, you should talk about any hyperesthesia or hypoesthesia over any part of the back. Also, if there is any abnormal pulsation. Also, see for any abnormal prominence or depression. Position of the vertebral prominence, that is the spinous process. You should always see whether the C7 is palpable or not. Also, it is a good practice in exam to mark each spinous process using a pen or a skin pencil. This you can start from external occipital protuberance to the tip of coccyx, and wherever you can feel the spinous process, you should try to mark it. Also, you should see the central furrow. Now, in that you should see the interspinous gap and also the spinous processes. Normally the interspinous gaps you can very well palpate by using the blunt part of your thumb, and spinous processes you can palpate by using the tip of the thumb. Also, you should see the paraspinal muscle spasm. Now in exam, the examiners might ask that how do you know it is paraspinal muscle spasm, or how do you exaggerate it? So you ask the patient to bend forward. In cases of painful pathology, like in case of port spine or any fracture, the paraspinal muscles, they become tight and they stand out. Now in cases where there is a long standing pathology, sometimes there is atrophy of the paraspinal muscle because of prolonged bed rest. So in those situations, this test may not be helpful and no paraspinal muscle spasm might be seen. Also, we should know about how to elicit tenderness. There is something known as direct pressure tenderness, in which we apply pressure over the spinous process, and this normally shows the pathology of the posterior element of the vertebra or any pathology which is widespread. Now the second type is the twist tenderness, which checks for the early pathology even in the anterior part of the vertebral body. Here we twist the spinous process and we check for any pain to the patient. Third is deep thirst tenderness, where we with the flat part of our fist, we gently tap over the vertebral body, over the spinous process, and to see if there is any pain. So there are three ways of checking the tenderness in spine. Also in palpation, if there is any cold abscess, then you should tell about the location of the cold abscess, how big it is, and also you should know in exam that if there is a cold abscess in this particular part of the spine, then from where it can come. Also in cases like if there is any spina bifida or spina bifida manifestation, then you should talk about the size, site, shape, content, impulse on cuffing, transillumination test for that particular swelling. Also, it is important that if there is any spondylolisthesis, then there is a palpable step. You should be able to palpate it in front of the examiner. It is important to check any tenderness over iliac crest or dimple of Venus, because tenderness over dimple of Venus can point towards a SI joint pathology. So don't miss out the SI joint when you are examining spine. Tenderness over SI joint is very important in all the exams, and if all the methods that I have just shown you to elicit the tenderness fails, then tenderness can also be elicited by using a rubber hammer. But this method is not approved by all the examiners in the exam. So you should be very choosy about telling this to the examiner, because most of the examiners say that you cannot cause so much pain to the patient. So this rubber hammer method of eliciting the tenderness, just keep it to yourself. If the examiner asks for any more method after you have demonstrated all the three methods, then you can mention about this rubber hammer technique for eliciting the tenderness. Also, one important thing is in SI joint, if you press the fibrofatty nodule, sometimes you can get a sciatica type pain traveling down the leg. This is known as pseudo sciatica. This is not a true sciatica, and this pseudo sciatica can be present in numerous patients. So if the examiner presses over the SI joint and there is a complaint of pain over the leg, that is a trick question. You should know that it is pseudo sciatica and not true sciatica. Now let's understand the movement of the entire spine. So this nodding movement, it happens at the atlanto-occipital joint, which is a condylar sort of joint. Now this side to side movement, it occurs in the atlantoaxial joint, that is between the C1 and C2, which is a pivot sort of joint. Now let's see the movements and the measurements occurring at cervical spine, thoracic spine, lumbar spine. Also, let's talk about the occiput to wall test in ankylosing spondylitis and other special tests. Now for testing the movement of cervical spine, let's first start with the flexion and extension. So for that, you ask the patient to hold a scale like this and then to bend the neck fully. Bend the neck as much as possible. So normally the patient is able to touch the chin to the chest. And when you are testing this, the flexion is around 80 degrees in cervical spine. This is the normal range of movement. So you put the scale in the patient's neck, patient's mouth, and then you bend it. So either the sternum should touch the jaw, or if the patient is not able to do it, then supposing if there is a lag like this much, then what you have to do is you take this, you measure this angle with that of the horizontal. When you measure this angle with the horizontal, then that is the amount of flexion that you are getting. Similarly, for extension, you ask the patient to look as up as possible. So normally this is the extension that can be achieved. This is around 50 degrees. So 50 degrees of extension and 80 degrees of flexion is the normal cervical spine range of movement when it comes to flexion and extension. Here also, to the horizontal, you measure this angle. This gives you the amount of extension that the patient can do. Take care, normally better. Flexion is normally done by sternocleidomastoid muscle, and the nerve involved is spinal accessory nerve and C2, C3. Extension is normally done by trapezius and muscle and nerve from spinal rami C3 and C4. Next is to check the lateral bending movement of the cervical spine. For that, again, you ask the patient to take the scale and put it in his mouth like this. Then you ask the patient to tilt the neck as laterally as possible. Normally, when the patient is able to do this, you measure this angle with the horizontal. This angle is around 45 degrees. Similarly, you ask the patient to do it on the opposite side. Here also you measure this angle. Ideally, the angles on both the sides should be the same. Next, we come to the side bending movement of the cervical spine. So for this, you ask the patient to bend his neck to the sides as much as possible. Normally, the patient is able to bend till 80 degrees. If you want to assess this in a better way, you look from here, from the top. Because while doing this test, you can ask the patient to sit on a stool which is low lying. So the patient rotates his neck like this and then to the opposite side. Using this scale gives you a benefit when you are viewing from the top and you want to measure the angle with respect to the vertical. So for testing the flexion, we ask the patient to bend forward. आगे झुको आप, जितना झुक सकते हो. So a normal healthy person may be able to touch the floor or touch his toes like this. But sometimes if somebody is not very flexible, then even if somebody is able to reach between 7 to 10 centimeters, ideally between 10 centimeters of the ground, or able to reach up to the middle part of the tibia, that should be taken as normal. So when we do like this, there is flexion at both lumbar spine as well as at the thoracic spine. So majority of the flexion occurs at the lumbar spine, but some of it is contributed by the thoracic spine as well. So when the patient is doing this movement, the muscle which acts primarily is rectus abdominis muscle, which is supplied by the intercostal nerves. Similarly, we test for the extension. So for that we ask the patient, ऐसे पीछे हो जाओ. Now important thing here is that the hand should be freely hanging and the patient should not try to do this movement. This is wrong if patient is trying to doing an exam. Hand should be freely hanging. So when the patient tries to do like this, normally the amount of extension that we get is around 30 degrees. And for measuring this, we measure this extension with regard to the vertical. Like if there is a line vertically drawn here, then this angle is around 30 degrees. And this movement is primarily done by sacrospinalis and quadratus lumborum. Now for testing the lateral bending of the spine, we ask the patient to bend sideways like this. And we see what is the gap between the tip of the fingers and the floor. We measure this gap on both the sides and compare it. Second method is we see if the patient's finger are able to go past the knee. In majority of the situation, the patients, even normal patients, are able to make the fingers reach up to the popliteal fossa. But if somebody is flexible, he might be able to get his fingers past the knee itself. The third thing that we can do, or the third way of measuring the lateral flexion is, you ask the patient to bend like this, and then from the back, पीछे घूम जाओ, अब साइड में bend करो, and from the back, you measure the angle of his spine with that of the vertical. So this angle should be around 30 degrees. So there are three ways of measuring the lateral flexion. That is, when you measure the spine angle with the vertical, when you measure the distance between the tip of the finger and the floor, and third, whether the patient is able to reach past his popliteal fossa or not. So now coming to testing the rotations of the thoracic spine, we ask the patient to place both the hands over the iliacus like this, and we ask the patient to rotate the upper body. Jitna rotate kar sakte ho maximum, utna rotate karo. Now how do we measure this rotation? We see the axis of pelvis. Basically, pelvis axis would be like this, and the axis of shoulder axis be like this. So normally the angle that is formed between these two axes should be around 40 degrees. So special test for lumbar PIVD case. Suppose if we have a L4-5 or L5-S1 lumbar intervertebral disc prolapse, and the patient is complaining of radicular pain, say going down the right lower limb. Then the special test always starts with well leg raising test first. We ask the patient to lift up his well leg, that is the leg that is not paining. And normally this should be free. The patient should be able to lift the leg up himself, which is known as active. Or we should be able to lift the leg straight up with the knee totally extended up to any level possible. So this is well leg raising test. This is positive only in cases if we have a huge central disc at L4-5 or 5-S1. When raising this leg up causes pain in the right lower limb. So this is the first test, that is well leg raising test. Second is in the leg that is affected, that means the leg in which we have the radicular pain going down. We do SLR. First we ask the patient to lift the leg up straight himself. So पैर उठाओ अपना ऊपर जितना उठा सकते हो, like this. Supposing if the patient is complaining of radicular pain going down the limb, say at 40 degrees, then we call it as active SLR positive at 40 degrees. Now SLR is normally positive. The significance of positive SLR is between 30 to 70 degrees. Because between 30 to 70 degrees only the nerve starts to get a stretch. If it is positive before 30 degrees, then also it is relevant, and after 70 degrees it is equivocal because the hamstring might be tight in that particular patient. So first we ask the patient to do active SLR. In that, important thing is the knee should be straight. Then we do the passive SLR. For passive SLR, we keep one hand over the knee so that it is always extended, one hand under the heel, and then we lift it up till the patient starts complaining of pain. Supposing he is complaining of pain at say 60 degrees, so we call it passive SLR positive at 60 degrees. Now the modification of this is, if the patient is complaining of pain supposing at 60 degrees, we lower the leg little bit so that the pain goes away, and then we dorsiflex the ankle. When we dorsiflex the ankle, the nerve again gets stretched, and there is a positive, this is known as positive Breguet sign. So if because of the dorsiflexion the pain reappears, the test is positive. Similarly, supposing if active SLR or passive SLR is positive at 60 degrees, we bring it again down to 50 degrees. This time we don't dorsiflex the ankle. We push the popliteal fossa hard using our palm. Because of this, the nerve gets stretched again. This is known as positive Bowstring test. So this is another special test for nerve stretch. Now the third test in this continuation is the Faber's test or the Patrick's test. Now the next test is the Faber's test or the Patrick's test. For that, on the involved side, we lift up the patient's leg like this. We keep the ankle free and over the thigh. We have to make sure that the entire leg here is above the knee level. We stabilize the ASIS using one hand so that there is no rotation of the pelvis when we do this. And then with the other hand we apply pressure over the knee joint in the downward direction. So I stabilize the ASIS like this, and then I push the leg down. So now this test can be positive in three ways. If there is any hip joint related pathology, like arthritis or something else, then the patient will complain of pain here at the hip area. And also we might not be able to push the leg below the level of the other leg. That means this leg will remain, this knee will remain above the level of other leg. Secondly, if the patient is having SI joint problem, then patient will complain of pain here at the SI joint region. Or third, if patient is having lumbar PIVD, especially of the lower nerves, especially say at L4-5 or L5 region, then when I'll do this by fixing the pelvis, patient might complain of pain going down the leg. Below the knee, if there is a radicular pain on doing this test, then it is positive for lumbar PIVD. Now, continuing with the other forms of special test, we have already discussed about the sitting SLR. That means we ask the patient to sit, and while sitting, if the patient complains of similar pain traveling down the leg, then this is sitting SLR, or this is again SLR test positive. Similarly, we can also do it by making the patient sit on the side of the couch like this and lifting the leg up. When we lift the leg up, again the nerve gets stretched and the patient might complain of pain traveling down the leg. Or if the pain is too severe, patient might even lean backwards, support the body using the arms, and this way he can relax his nerve and the pain goes down. Now these tests were all for L4-5 or L5-S1 related disc issues. Now if there is a disc higher up, say in the upper lumbar spine, and the femoral nerve is getting stressed, then we do what is known as a femoral nerve stress test, or sometimes it is also called as the reverse Lesigus sign. So for that we ask the patient to lie on the tummy. अपने पेट पे लेट जाओ. We flex the knee like this and then we raise it. So while doing this maneuver, if the patient complains of pain traveling down in the distribution of the femoral nerve, then that indicates that there is a disc high up which is pressing the nerve, femoral nerve, and that is eliciting the pain going down the leg. So this is known as the femoral nerve stress test for disc high up in the lumbar spine. So the next special test in this sequence is the lateral bending test. If some person is having disc problem at say L4, L5 or L5-S1 and he has radicular pain going down the leg, supposing in this case if we say towards the right side the radicular pain is there, we ask the patient to bend to the opposite side. If while bending to the opposite side the pain in the affected leg increases, then it represents that the pressure is from the medial side. So basically, if the person is bending on the opposite side, it might be an axillary disc. On the contrary, if bending onto the same side, increases the pain on the affected side, then the pressure is from the lateral side. That is, the pressure is from the lateral side of the root. Then it might be a shoulder disc. So this test helps us to distinguish the location of the two discs based on the clinical assessment when we bend the patient to the opposite side or to the ipsilateral side, and which bending increases the pain in the leg. Now in your exam, if you get a case of ankylosing spondylitis, then you are supposed to know the special test for SI joint. So SI joints lie here. So for that, you ask the patient to lie down supine like this. For the first test, which is known as the pump handle test, you take the patient's knee and you bend the knee and then direct this knee towards the opposite shoulder, and then you apply a pressure. If the patient complains of pain over the SI joint, then this is a SI joint stretch test, and that means the SI joint is involved. Now the next test is the Faber's test or the Patrick's test. For that, on the involved side, we lift up the patient's leg like this. We keep the ankle free and over the thigh. We have to make sure that the entire leg here is above the knee level. We stabilize the ASIS using one hand so that there is no rotation of the pelvis when we do this. And then with the other hand, we apply pressure over the knee joint in the downward direction. So I stabilize the ASIS like this and then I push the leg down. So now this test can be positive in three ways. If there is any hip joint related pathology like arthritis or something else, then the patient will complain of pain here at the hip area, and also we might not be able to push the leg below the level of the other leg. That means this leg will remain, this knee will remain above the level of other leg. Secondly, if the patient is having SI joint problem, then patient will complain of pain here at the SI joint region. Or third, if patient is having lumbar PIVD, especially of the lower nerves, especially say at L4-5 or L5 region, then when I'll do this by fixing the pelvis, patient might complain of pain going down the leg. Below the knee, if there is a radicular pain on doing this test, then it is positive for lumbar PIVD. Now the third test for SI joint is, we expose both the ASIS, we keep our thumb over it, and then we try to distract the pelvis. That is, I apply a force outwards. So I apply a opening up force on the pelvis. So because of this test, if patient complains of pain in the SI joint area, this is also a confirmative test. Similarly, if I try to compress the pelvis, this is known as pelvic compression test. If I try to do this and then also patient is complaining of pain in the SI joint area, then this is also a diagnostics test. Now the next test is Ganselin's test, for which you ask the patient to move to the edge of the table. Move out and hang this leg freely so that the pelvis is rotated here and fixed. Now the other leg you slowly flex like this and hold it firmly against the chest. So because of this, the SI joint is stretched here. So if the patient complains of pain during this maneuver, then this test is positive, and this is known as the Ganselin's test for SI joint. So coming to the special test in cervical spine examination. For cervical spine test, the first test is L-Hermite sign, which is a special test in which we ask the patient to bend the neck like this. If because of this bending there is electric current like sensation traveling in the arm and in the leg, especially in the leg, then this means there is some problem in the upper cervical spine or near the brainstem region. But this test is not diagnostic of cervical spine pathology. Always remember that this can happen in B12 deficiency, multiple sclerosis also. So when you do this and the test is positive, it might be because of some pathology which is pressing the upper cervical spine region, especially the posterior column of the spinal tracts, because of which this current is flowing down the leg. Now the second special test is the hand on the head sign. Whenever there is a radiating pain traveling down the arm, if there is a radicular pain and the patient keeps the arm like this, he will complain of severe pain because of the nerve root stretch. But as soon as he will take the hand up and keep over his head, basically hand over head sign. So this relaxes the stretch on the nerve because of the prolapsed disc or any pathologies that is stretching the nerve, and the patient's pain will disappear. This test is also very relevant because in history itself the patient will tell you that when I keep my hand over my head like this, especially in the night while sleeping or while traveling, it gives me relief. Now coming to the third test is known as the compression test. So if the patient is sitting like this and complaining of supposing pain radiating down this arm because of the disc prolapse, and you ask the patient to sit straight like this, then very gently you apply a compression on the cervical spine. Now the important point here is you should not give jerk. You should not do like this. You should apply a stable and gradual pressure, and then slowly you should increase that pressure. So supposing you are keeping hands like this and you apply a vertical compression force and the patient complains of pain, increase in the pain, then this test is positive. Similarly, another modification of this test is when we bend the neck like this, say to 30 degrees or 45 degrees, and then we press again. So when we do like this, if there is a disc in the spine which is pressing the nerve, when we do like this, the area for the disc becomes very less. And on top of that, when we do compression, the area becomes even less. So this test causes even more pain radiating down the arm. So if vertical compression test is not positive, then only you should do this test. If the vertical compression test is positive and you go on and do this test, the patient might even complain of severe pain or might end up with some neurodeficit. So now the third test in the same sequence is when we do a cervical distraction test. Supposing if patient is complaining of pain going down this arm, we hold the hand, we keep our fingers under the jaw. With this thumb, I stabilize the posterior part of the head, and then I pull the patient's neck towards the ceiling. When I do this, there is a distraction or there is a traction in the cervical spine, because of which the space for the nerve increases. So this reduces the pressure onto the nerve and the pain in the arm reduces. So all these tests are special tests for cervical spine disc prolapse. These are stretch tests. Now coming to the next test, which is the lateral compression test or the lateral stretch test. In this test, we ask the patient to simply bend the neck to the affected side. If while doing this test, the radicular pain in the arm increases, that means there is a pressure on the disc, there is a pressure on the nerve from the lateral side. Similarly, if while doing this test, the pain in this arm increases, then that means that there is a pressure on the nerve from the medial side. That is, the pathology is medial to the nerve. So now coming on to the next test. The next two tests are basically for thoracic outlet syndrome. You should know two tests for thoracic outlet syndrome, because very commonly in DNB or MS exam, the examiner asks you to differentiate between cervical spine pathology and thoracic outlet syndrome. So the first test is the Addison's test, in which you take out an externally rotate, you abduct and externally rotate the patient's arm to say around 30 degrees. You keep, you take a measure of the patient's radial pulse. You ask the patient to bend the neck towards the affected side and ask the patient to take deep breath. गहरी सांस लो आप, गर्दन ऐसी रखते हुए. So while doing this maneuver, if there is a drop in the radial pulse, then that means that there is a positive thoracic outlet syndrome possibility. Similarly, the other test is the Roos test. For this test, you ask the patient to take the surrender position, in which the arm is abducted, externally rotated, elbows are flexed, and then you keep both your, you take measure of both the radial pulses, and then you ask the patient to repeatedly close the hand and loosen it for 3 minutes. अपनी मुट्ठियां बंद और खोलो, ऐसे ऐसे करो, हाँ. And you take a measure of the radial pulse. While doing this, if you feel after some time there is a difference between the radial pulse on both the sides, or the patient starts complaining of numbness, tingling, or pain in the arm, in any particular limb, then the test is positive. One modification of this test is when you ask the patient to take deep breath in between and hold it, say for 30 seconds or 40 seconds, and then you perform this test again. So these two tests are specific for thoracic outlet syndrome. So these are some of the special tests in cervical spine that you are supposed to know for your MS or DNB exam. Straight leg raising test is a very common test that is asked in almost all cases of PIVD at L4-5 or L5-S1 in DNB or MS exams. So for straight leg raising test, first, if the patient is complaining of pain, say in the right lower limb, then first you ask the patient to raise the left leg. अपना ये पैर उठाओ हवा में, ये वाला सीधा रखते हुए. So you ask the patient to move the leg that is not paining. Ask him to lift it straight as much as possible. जितना भी ऊपर उठा सकते हो उठाओ इसको. Good. Okay, नीचे रख दो. So now for SLR or straight leg raising test, first you do it actively. Basically, when you ask the patient, अब ये वाला पैर उठाओ हवा में सीधा ऊपर, like this. So when the patient is lifting the leg up, supposing if he was able to lift this leg, the normal leg completely, in this leg when he is trying to raise, supposing at 40 degree he is saying that now he is getting pain, and the pain is traveling throughout the leg, basically going below the knee, that is important. So that tells us that now the nerve is getting stretched. So always do it with the normal leg first, then do it with the affected leg. So when the patient is himself doing it and telling you that okay, at this level I am getting pain, this is known as the active SLR test positive. When you do it, and for doing it you have to keep your one palm over the knee and other palm under the heel, and then you slowly raise it, and then you try to raise it as high as possible. Supposing at 50 degrees patient is saying now he is having pain and that pain is traveling down the leg, so we call it passive SLR test positive at 50 degrees. Now one flip side of it is, if patient is having predominant symptoms say on the right side, but when you try to lift the other leg and then at some point he is saying that because of lifting this leg up he is having pain radiating down the affected leg, that is the right leg, that means that either there is a huge disc, basically a huge disc which is pressing both the sides, but right side more than the left. Whenever there is a huge central disc, then this is, and patient is complaining of pain on the affected side, when you lift the non-affected side, that is known as well leg raising test positive. So this leg causes pain in this leg because of huge central disc at L4-5 or 5S1. This is known as well raising test positive. So now coming to few modifications of straight leg raising test. First modification is, supposing if you want to know whether the patient is malingering or he is telling you the truth, you simply ask the patient to sit. Back down. If the patient is able to sit comfortably like this, that means there is no stretch pain going down the leg. This is a test to distinguish between malingering patient and true SLR positive patients. If the patient is having pain while sitting like this, then most of the time patient will say, okay, I'll keep my hands like this, and he will lean back slightly so that the stretch in the leg reduces. So if the patient is sitting like this, that means he is telling you the truth and there is a pain radiating down the leg. Similarly, one more method of doing SLR is, you ask the patient to sit down like this. When the patient is sitting like this, the knee is flexed and there is no stretch on the nerve. Then while you just keep on talking to the patient, and then you lift up the leg and try to make it totally straight. Now if you can see, this is also a straight leg raising test. So if the patient is telling you the truth, he will immediately lean back and he will keep his hands by the sides like this, and he will try to relax his nerve. So if the patient is going into this position, this is known as the tripod sign. If the patient goes into this position, that means the sitting SLR test is also positive. So one case that you might get in exam is ankylosing spondylitis. Now there are few special tests that you are expected to know when you appear for the exam. The first is occiput to wall test. So for this you have to stand, you have to make the patient stand against the wall like this. The heel should be touching the wall, the buttock should be touching the wall, and the patient should try to stand close to the wall, as close as possible. Now the important thing here is the occiput should be touching the wall. If the patient is not able to make the occiput touch the wall, that means the thoracic kyphosis has increased and there is a forward stoop or a bend. So if the patient is not able to make his occiput touch the wall, then that is a positive sign. However, this is not a diagnostic test for ankylosing spondylitis because a lot of patients are not able to do so. But if the distance is more than 10 centimeters, then it is definitely confirmative. The second test is tragus to wall test. In this, we ask the patient to stand like this. We measure the distance of tragus from the wall, and we do it on both the sides. We do it on both the sides, then we take the average of it, and it should be less than 10 centimeters. If it is more than 10 centimeters, then it is confirmative. The third test for ankylosing spondylitis is we measure the chest expansion at the level of nipples. So we ask the patient to hold it, and we go around the entire circumference and then we ask the patient to fully inhale from a fully exhaled position. गहरी सांस लो. So when we do this, the minimum chest expansion should be 5 centimeters. Normally, if it is more than 5 centimeters, it is for a normal individual. So for a normal individual, it can be 5 to 8 centimeters. However, in cases of restricted pulmonary disease or some other pathology, it can be between 2 to 5 centimeters. So between 2 to 5 centimeters, it may be suggestive of ankylosing spondylitis. But if it is less than 2 centimeters, then it is definitely suggestive of ankylosing spondylitis. Now, moving on to the third special test. The third special test is we ask the patient to repeatedly bend forward, get up and do the rotations. If while doing this, supposing if you ask the patient to do this for 2 minutes, थोड़ी देर के लिए बार बार नीचे झुकना है, सीधा होना है, हाँ, ऊपर हो, हाँ, बार बार करो, जल्दी जल्दी करो, बार बार, हाँ, गुड. अब ऐसी दूसरी तरफ रोटेट होना है, ऐसे ऐसे करो, हाँ, ऐसे ऐसे. So you ask the patient to do this maneuver for 2 minutes. If after 2 minutes patient says that he is actually feeling there is more flexibility in his body and he is feeling better, then this test is known as the stress test. In this, basically when the patient moves, the movement improves, the flexibility increases, the pain goes down, so the patient starts feeling better. This is based on the same principle that in an ankylosing spondylitis patient, when he gets up in the morning, he is stiff, but when he moves around, he becomes better. So that is because the movement increases the flexibility, reduces pain, and increases the overall movement of the body. So the next test now is the Schober's test. For this, we ask the patient, पीछे घूम जाओ. Yeah, we ask the patient to stand like this. Then we mark both the dimple of Venus and we join them through a line. This marks the lumbosacral junction. Now, using the scale, we take a point which is 10 centimeters above this line. And then we ask the patient to bend forward. Aage jhuko. Now, as you can see here, this distance has increased. Now, normally this distance should at least increase by 5 centimeters. So, this is known as Schober's test. A modification of this test is when we take a line which is 5 centimeters below lumbosacral junction. So when we mark this line which is 5 centimeters below and we measure the flexibility increase during this entire length of 15 centimeters, this is known as Schober's test. अब आगे झुको. Now as you can see here, the distance has increased tremendously to over 8 centimeters. So, so in this case, important thing to remember here is whether you do Schober's test or modified Schober test, the result is that minimum 5 centimeter increase in the length should be there. In a normal individual, this is almost close to 6 to 8 centimeters. In case of ankylosing spondylitis, because the flexibility goes down, this distance may very well be less than 5 centimeters. So this is how Schober's and modified Schober tests are done in exam and how it is interpreted. Now, in ankylosing spondylitis, we definitely need to do special tests for sacroiliac joints. We have a separate video on sacroiliac joint special tests. You can go through that video. In that we have demonstrated Ganselin's pump handle test, compression test, distraction test, Faber's test. So all the special tests for sacroiliac joints are demonstrated in that particular video. Thank you. Now let's start about the motor examination part, and let's start it with the bulk of the muscles. So it is important here that you compare both the limbs in symmetrical position and at the same place. So you should talk about the atrophy or the hypertrophy. Like atrophy happens in case of lower motor neuron lesions where there is weakness, like in case of foot drop, you will eventually see that the calf is also becoming thin and the foot is also becoming thin. So in cases where there is spasticity, you might not find this atrophy. Also, you should check for any pliability or flabbiness on difference on both the sides. If required, you should do a circumferential measurement of the muscle bulk also. It is important that you do it in a very comparative way, so that you do it in the same position for both the limbs and at same place. You can pick up any bony landmark, like you can say 4 centimeters below the level of lower pole of the patella. I have measured it, and on the right side it is this much, and on the left side it is this much. Next is that we should talk about the tone. Now one definition that most of the examiners love is about what is tone. So you should know that it is a state of tension found in the healthy muscle at rest. So there could be hypertonia or hypotonia. Hypertonia is normally seen in case of upper motor neuron lesion, like in case of cervical myelopathy, or if there is pot spine at the level of spinal cord. Also, in cases where you see hypotonia, it is seen in element types of conditions, like in lumbar PIVD, or if there is pot spine at the level of L4, L5. It is important to know here that hypertonia is basically because of the corticospinal tract involvement that causes spasticity. And also you should know what is clasp knife sort of spasticity. And also you should know what is basically what is rigidity, because extrapyramidal fibers when get involved, like in case of basal ganglia, you get rigidity. So it could be cogwheel type of rigidity or lead pipe. So basically lead pipe is basically throughout the movement it is present, and cogwheel type is jerky. You get it in intermittent phases. And clasp knife, which I spoke about, it is basically at the start of the movement there is tightness, then later on it becomes loose. Next, come to the power examination. So basically, whenever you examine power, it should be done symmetrically on both the sides in same position. So as per the Medical Research Council scale, it is known as the MRC scale. 0 stands for paralysis, 1 stands for flicker movement, 2 stands for movement present but gravity eliminated, 3 stands for movement is possible with gravity also, against the gravity also. 4 is that the movement is possible and the examiner applies some resistance, but it is less on one side as compared to the other. So basically against the full resistance, patient is not able to make the movement here. And grade 5 is normal, when the examiner is applying full resistance and still the patient is able to do it equal on both the sides. Now coordination part, normally this part you can skip for DNB or MS exam. It is never asked in detail, but you should know what are the various coordination tests. So basically knee to heel test is 1, finger nose test is 2nd, index finger tip test is 3rd, dysdiadochokinesia is 4th. And also you should know about the Romberg sign, because Romberg sign is sometimes asked in case of cervical myelopathy also. So it is important, and this we'll be discussing in detail in our video also. Now before we see different type of reflexes, let's first know the grading of reflex. So 0 means the reflex is not there, 1 means that it is a depressed reflex, 2 means it is a normal reflex, 3 means it is exaggerated, and 4 means it is clonus. So a lot of examiners ask you what is grade 2. So that means normal. Don't get confused in the exam. 2 stands for normal. So now for eliciting the biceps reflex, we ask the patient to keep the forearm semi-pronated over his chest. It should be loose. And I take my thumb, I keep it over the biceps tendon here. I palpate the biceps tendon here, I keep my thumb over here, put patient's arm semi-pronated over chest like this. Now using the sharp end of the hammer, I tap over the biceps tendon. Basically I tap over my thumb and I see the response of biceps muscle. So when this happens, there is a contraction of the biceps muscle here. Either you can look for this response, or there is a flexion of the elbow, because biceps is a flexure of the elbow. The root value of biceps reflex is C5, C6. Now for the next deep tendon reflex, which is the brachioradialis or the supinator reflex, we keep the patient's arm like this. The forearm should be slightly pronated, semi-pronated position. We feel for the radial styloid here, and with the hammer we strike over that area using a blunt end like this. So the normal response is there is slight supination of the arm because of the supinator muscle getting excited. Also because of the brachioradialis muscle, there is slight flexion of the elbow, not much. So the normal response is basically slight supination and slight elbow flexion. Now when there is an inverted supinator reflex that is seen in UMN lesions, upper motor neuron lesions, because of the spillover effect to C7, C8, because the inhibitory response of the upper motor neuron lesion is lost, so there is a spillover effect. So when we do the same reflex, and if there is an inverted supinator reflex or there is a UMN lesion, there is a finger flexion contraction here. So the normal response is lost. But when we do the strike over this area, that is the radial styloid, there is slight finger flexion, which is because of the C7, C8 spillover effect. This is known as inverted supinator reflex. So for eliciting the triceps reflex, you have to lift up patient's forearm and place it comfortably over your arm like this. Ask the patient to leave the entire weight over your arm. Now you have to use the blunt end of the hammer, and when the elbow is flexed to 90 degrees, the triceps tendon is primed. When it is primed, you hit like this, and then you see for the contraction of the triceps muscle here, or there is a extension of the elbow, because triceps is the extensor of the elbow. So either you look for the triceps contraction here or extension of the elbow here. The root value of triceps reflex is C67. So in deep tendon reflexes, the most common reflex that is asked in exam is the knee jerk or the knee reflex. For this, we make the patient lie supine like this. Make sure that the quadriceps muscle is well exposed, because this is a reflex of the quadriceps muscle. Root value is L, 2, 3 and 4. We flex the knee a little bit, place one hand on the opposite knee, then we place it like this so that the knee is slightly bent. This primes the quadriceps tendon, and then using the blunt part of the knee hammer, reflex hammer, we gently tap over the stretched patellar tendon, and we look for the response of quadriceps contraction here in this part of the knee. So the other method of eliciting knee jerk is you ask the patient to sit like this. Again, the quadriceps should be exposed, the leg should be freely dangling, and we hit over the patellar tendon again like this. So when we hit like this, there is a response. Either you can see for quadriceps extension here, or there will be slight jerk in the leg like this. So this response is what we see when we hit the patellar tendon in a freely hanging leg. More pathological responses that are seen in upper motor neuron lesion related to the knee or the knee jerk are when we keep our tip of the middle finger over the upper fold of patella and we tap it gently using the hammer. If the patient is having UMN lesion, then there will be a sudden movement of the kneecap downward followed by quick oscillation upward. This is patellar jerk. Secondly, if there is patellar clonus, which is seen in severe cases of upper motor neuron lesion, then using these two fingers, you first stabilize the leg like this, then using these two fingers, you suddenly push the patella downwards and then release it. So the patella keeps on oscillating like this. So these oscillations, if they are persistent, they are a sign of upper motor neuron lesion. This is known as patellar clonus. So now moving on to the next important reflex, which is known as the plantar reflex. For eliciting the plantar reflex, you have to position the patient like this. You have to take a sharp object. You can use the back of an examination hammer, and you have to start from the outer aspect of the foot and move like this. So this is the normal response that you see. So in a patient who is normal, there is inversion of the foot, dorsiflexion and flexion of the toes. So this is the normal response. But if there is a patient with upper motor neuron lesions like cervical myelopathy or dorsal compressive myelopathy, then there is a Babinski response. In Babinski response, there is an extension of the great toe, fanning out of the other toes and dorsiflexion. Sometimes what happens, if the Babinski response is too exaggerated, then there is slight flexion of the knee also. Now this Babinski response, this happens in response to the loss of inhibitory effect that is coming through the corticospinal tract. So whenever there is a compression in cervical or say dorsal spine and there is a UMN lesion leading to corticospinal tract compression, then the ascending sensory fibers or the ascending sensory signals that are going up are not inhibited by the corticospinal tract. So there is a spillover effect. There is a spillover to the surrounding nerves also, basically to the L5 and the L4. So because of that spillover effect, there is a dorsiflexion of the great toe, L5 response, and also this movement, and sometimes flexion of the knee also, which is the L4 effect. So Babinski response is basically a spillover effect that happens because of the inhibitory response, because of the inhibition of corticospinal tracts. Now the normal root value of this reflex is L5 and S1. Now there are few variations of eliciting the plantar reflex, like when we squeeze the tendoachilles, it is known as Schaeffer's sign. Similarly, when we squeeze the calf muscle and it elicits the response, it is known as the Gordon's reflex. Similarly, when we press hard over the anteromedial aspect of tibia and there is a response, that is known as the Oppenheim sign. Thank you. Now coming to ankle clonus, the correct method of eliciting ankle clonus is you have to flex the knee little bit, hold the calf or the muscle from here. This hand should come over the forefoot region from the plantar surface, and then you give a sudden jerk like this. So whenever there is a UMN lesion, upper motor neuron lesion, and there is a clonus, so when you do like this, the leg will oscillate. The foot will oscillate like this for some time. If it is a sustained clonus, as long as you apply the pressure, it will keep on oscillating. If it is a ill-sustained clonus, then after few repetitions, it will stop. So the next common deep tendon reflex that is expected in the exam is the ankle reflex. So for ankle reflex, you keep the leg in this position. Basically, you keep the ankle over the opposite shin. You dorsiflex the ankle slightly, very slightly, so that the tendoachilles is primed. Then you expose the calf area of the leg, and using the blunt end of the hammer, after dorsiflexing the ankle little bit, you tap over the tendoachilles. So the normal response of this reflex is slight plantar flexion of the foot, or there is a contraction of the calf muscle, which you can see as well as feel here in this part. So this response is through the nerve value S1 and S2. So now the next important superficial reflex is the abdominal reflex. This reflex carries a special weightage because this reflex is used for distinguishing upper motor neuron lesion from lower motor neuron lesion. So for doing this reflex, we need to expose the abdomen like this, and now starting from the outer quadrant, we go towards the inner quadrant like this. So when this happens, you can see there is a contraction in the abdominal wall. We test this on both the sides and then we compare them. So if upper motor neuron lesion is there, then this superficial reflex, abdominal reflex will be absent. The root value of this reflex is from T8 to T12. So if this test or the abdominal reflex is absent, that means there is a pathology high up, basically above the level of T8, that is causing compression on the nerve, and it causes upper motor neuron lesion, which leads to diminution or absence of this abdominal reflex. Now this reflex can be absent in fat people, or women who have undergone previous multiple pregnancies, or people who have undergone abdominal surgeries in the past. So whenever interpreting this result, you should also compare it on both the sides, that is on the right side and the left side, for any discrepancy in the response to this reflex. Now the next reflex is the scapular reflex, which is a superficial reflex. So for this reflex, you have to expose the back of the patient like this, and you have to use the blunt end of the hammer. Using this blunt end, you have to scratch the skin from up to down in the interscapular region and look for the reflex. So when I'll do it, so the scapular reflex is a superficial reflex which is found in normal individuals, and the root value is between C5 to T1. Now let's talk about the sensory examination. It is important to understand here that you should know the dermatomal pattern or the dermatomal chart, whether for the upper limb or the lower limb. You should know which nerve is supplying which part. So have a look at these charts so that you know where to test for which dermatome. Now normally in exam, you just do superficial touch or pain temperature charting. So normally it goes like this. With a cotton and the patient's eyes closed, you have to check symmetrically for the superficial touch in a particular dermatome on both the sides. This basically shows about the intactness of the posterior column of the spinal cord. The posterior column of the spinal cord carries sensation for superficial touch. Also, if available, you should use a hot or cold test tube to test for pain and temperature. Now, this is carried on by the spinothalamic tracts for the pain and temperature. Also, you should check for 2-point discrimination, vibration or joint position test if required, but otherwise in DNB or MS examination, normally superficial touch using a cotton, pain and temperature or deep touches what the examiner normally expect out of you. If you want to test for vibration, you should use a tuning fork, and joint position sense should also be done with the patient's eyes closed. Now, 2-point discrimination, stereognosis, these are basically cortical sensations. So in exam, you should know, if the examiner wants to go into detail, this is the maximum that you need to know for your exam, that posterior column is tested when you do joint position sense or vibration test or fine touch using the cotton. If you are testing for spinothalamic sensations, then that would be pain, temperature and crude touch. If you are checking for cortical sensations, then it would be 2-point discrimination or stereognosis. Before you end your examination, you should also comment about the blood supply. So for that, ideally you should know 3 vessels, or you should have palpated these 3 vessels. Now, first is the dorsalis pedis, second is the posterior tibial, and third is the radial. You should comment upon whether they are felt, they are not felt, or they are symmetrical, or if there is any abnormality. With this, you can say that your examination is complete.